Okay, and welcome. Thank you for joining us today for our Recovery-Oriented Systems of Care webinar series, Empowering Communities to Address America's Mental Health and Substance Use Needs, Session 1. Today's webinar is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speakers and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you all. If you are having any technical issues, please individually message me, Alyssa Kuala, or Jen Winslow in the chat section, and we would be happy to assist you. Any questions for the speakers, please put them in the Q&A section of your toolbar. We will do our best to get those answered during the live webinar today. If captions or the live transcript would be helpful, please locate that option using your Zoom toolbar. You will be directed to a short survey at the end of today's presentation. It would be greatly appreciated if you could fill that out. And certificates of attendance will be sent out via email to all who attended today's session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube channel, and our podcast channel. And I'm super excited to introduce our presenters today, Dr. Flaherty, Precia Stuby, Zach Thomas, and Nichole Coleman. Thank you all for being here with us today. I think we lost Dr. Flaherty, guys.
Could we start with a poll while we're waiting on him?
Of course. So everyone, I will be launching a poll. It's going to be showing up on your screen, asking how familiar are you with recovery-oriented systems of care? Very familiar and work within ROSC, very familiar but not working within ROSC, somewhat familiar or not familiar at all. To my panelists, Zach, Precia, and Nichole, I'm not sure if you can see the results so far. Slowly, more and more responses are coming in, but we have a good mix of people. 29% of our group is saying very familiar and work within ROSC. 36% says somewhat familiar, and 25% says not familiar at all.
Thank you very much. I will leave this up to you, Alyssa, but I know that Dr. Flaherty was having some connection problems. If you would like me to go ahead and start so that we don't get too far behind, I could move to my presentation and then we could flip that back to him when he's on.
Yeah, I think that's perfect. Thank you.
Okay, Zach, I'll let you put on my presentation. Yeah, there we go. Good afternoon, everyone. You're getting second fiddle until Dr. Flaherty gets on, who's really going to give you a lot of the background and grounding in ROSC. But since we have such a mix of people with experience, I think it's okay if I go ahead and jump in. I'm here today to kind of give you an example of what it looks like in a single community. So Zach, I'll have you go ahead and punch in the next slide. I like to start each of the presentations that I have an opportunity to give with just a moment of gratitude. I know there's a lot of competing things for people's time, and I really appreciate not only your time that you're giving to this today, but whatever role that you have in the field. Thank you for hanging in there. I think with the workforce shortage, it's really important that we do that. I also want to take a moment to let you know that um, while I'm presenting today, I would not be in this position if it weren't for so many others before me who have pioneered this work to move it forward. So with that, Zach, I'll have you move to the next slide. One of the things you'll hear a lot from me today is that I am kind of a reframer, so to speak. In talking with so many people about the concept of ROSC, uh, instead of putting it in so many of the scientific and journal terms that we have, I'm the one that tries to translate it into English for all different systems in our community, and to help them understand. And so one of the concepts that I try and get across is the concept of uh, every individual having a story. And in everyone's story, there are times when we are the helper and times when we are the people that receive help. And our stories, all of our stories, are filled with moments and milestones. That can be a graduation, can be a first job, a marriage, an anniversary. We celebrate moments and milestones all along the way. One of the observations that I have from our community in terms of looking at addiction is that we used to define success as abstinence and failure as overdose or death. And I think that it's very important, particularly with the workforce shortage, for people to understand that any intervention that we have with individuals helps provide them with an opportunity for them to celebrate moments and milestones. Um, Even if a person does not make it for, they do overdose and die, a family and loved ones are able to hold on to those moments and milestones. And that's what we do when we think about other diseases. So if somebody struggles with cancer or something like that, we might say they made it to the wedding, they made it to someone's graduation, and so on. And we view all those things as successes. So when I'm speaking, I'm trying to get us to reframe and think about that it's not just about abstinence of death. It's about all those moments and milestones in between. Thank you, Zach. Next slide. The next kind of reframe that we talk about a lot in our community is, so many times individuals have a picture in their mind of somebody who struggles with addiction or somebody struggles with mental illness. And it's like those umbrellas. Everybody who has an addiction looks like that red and white umbrella. What we're trying to help people think about is to think a little bit differently about it. There's a lot of gradations, and there's a lot of individuality in terms of individuals that struggle with this disease. So to translate that into something that might be more practical for you, when I remember early days when somebody would be diagnosed with cancer, and it would nearly take the breath out of you because we associated cancer with death, and struggle. We've come a long way with that, and now when we think about cancer, we think about what stage and where is it? So everybody with cancer is not a red and white umbrella. They're more over there in the different grades where we say, well, it's stage 1 colon cancer, or it's stage 4 brain cancer, or it's stage 3 breast cancer. And each of those bring a different visualization to our mind in terms of the level of severity, maybe the types of intervention, as well as the length and time and intensity of treatment that might be needed. And so we're wanting people to think about individuals and their struggles a little bit differently, that everybody's struggle doesn't look the same way. So the next slide, please. So the approach that we adopted is ROSC, which Dr. Flaherty will go back and go through all of that. But the way I try and think about ROSC is kind of like that jigsaw puzzle. So if you think of a frame of a jigsaw puzzle being the boundary for wherever you're working, if that boundary is a state, if it's a city, if it's a county, if it's an agency, whatever boundary that is, the goal of a jigsaw puzzle is once that boundary is set, there is all of the pieces fit inside that boundary. And so the goal with ROSC is to move that conversation from us and them, like somebody inside the boundary and somebody outside the boundary, and more to a concept of we. So whoever is in the boundary that you design, the goal is that we find a way that we all belong, that we all are working on solutions, and that we're all trying to support individuals that are struggling. Next slide, please. So it doesn't just sound good. When we made the decision to go move forward with ROSC, I think one of the things that was most compelling for us is that the increased likelihood of an outcome going up by anywhere from 10 to 15%. So if we had an evidence-based practice and it said it worked half the time, if you do it within a context of the philosophy of ROSC, you end up increasing that 50% to up to 65, which, if you think about another disease and say you were dealing with cancer and you had a 50% chance of getting better and that 50 went to 65, we would think that was huge. And so that's the way we think of it in our community, as it was the most compelling of all of the arguments for us to move forward with this. The second was that when Dr. Flaherty goes through all the principles and science, is that it applies to individuals, whether they're struggling with a mental health issue or an addiction issue. In our community, which is, we're a small community of about 75,000 people, we're considered a micropolitan. People in big cities would really think we're just really rural, but people in really rural areas would think we were a little more urban. So we're considered a micropolitan. And so we're not large enough to have a standalone mental health system and a standalone system for people who struggle with substance use. So it was important to us that we had a model and a philosophy that applied to both. And then the thing that I love the most is that no matter what, we can find a role for everyone. So we are one of the people that use that slogan that if you're not part of the solution, you're part of the problem. And so we don't leave anybody out. There's something for everyone. Next slide, please. So I first got introduced to the concept of ROSC through Dr. Flaherty, who we had contracted with to help us really work on our continuum of care for substance use. And when we met with him, he told me that he would only do it on one condition, and that was if we did it within the context of ROSC. And that was a term I had never heard of before. So I basically told him, if you teach me, I will learn. And so I have been his pupil for the last 11 years. But one of the things that was available to me through the Addiction Technology Transfer Center was a, a learning institute, a week-long learning institute that was put together by Dr. Achara, that helped us look at, like, if you were going to take this back into your community, how could you even break it down into building blocks? Because it's not just a service, it's not any one thing. So these are the big pillars that she broke it down into, and we actually adopted each of these pillars, and this is how we set forth our plan for moving forward. So, the first pillar really had to do with making sure that there was a complete continuum of care for individuals that struggle. And that was quite an undertaking for us, because in our community, we had outpatient counseling and referrals to AA community when we got started in this. So we spent many years building a lot of different services to fill the continuum. The second building block was really about doing everything in our power to mobilize the recovery community, have them come forward, have them be a part of everything that we do, have them help steer, guide, uh, and become a vocal part of our community so that we could spread the hope of recovery to all parts of our community. The system is not complete if we don't build in, how are we going to measure our success? How are we going to continue to evaluate and continue to improve? So there are things associated with that, as well as a focus not just on prevention, but then how do you move upstream? How can we take and assess what did or didn't work for somebody with a struggle, take that information and feed it back to our system so that our prevention services were reflective of what people were telling us was needed. And then a real focus on intervention. So it wasn't just having the service available. So wasn't just having medication assisted treatment. It was about what specific interventions and medication assisted treatment were we going to do. So that became, the availability of Suboxone and methadone and so on. So we think about, you have to have a continuum of services, but you also have to have evidence-based interventions within those levels of services that you provide. And then finally, the framework is dependent on alignment with the way you use your money and the rules and regulations you have in your organization. So with every turn, we're constantly trying to revise and look at what we have to make sure there's alignment with the philosophies of ROSC. So Zach, if you can move to the next slide. So as we went to look at developing services and kind of refining our discussion, the way we try and describe individuals who struggle in our community, similar to the stage 1, stage 2 kind of example I gave you with cancer, Dr. Flaherty helped us design the concept of a 3-story home. And if you think about the first floor of the home being individuals who have the insight that they know that they need help. And so they're like, I have a problem. I know where to go to get help. I'm going to go there. I'm going to listen to the recommendations they have, and I'm going to put that into practice and with hopefully get better. So one of the things we need to keep in mind is the vast majority of all of our systems were designed that way, where we built agencies and the expectation was that people would come to our door to get the treatment. And what we realized is that's very, very helpful for people that live on the first floor. But there's a group of individuals who live on the second floor of the house, and those are individuals who they don't get help without a nudge. That can be the threat of a loss of employment, the threat of a loss of a relationship, a run in with the law. So now you have a legal record and so on. So there's something that just has that outside nudge, that wake up call, that nudge to keep you engaged and get you to receive care. So that's how we think about that second floor. And it involves not just having those services for people to come to us, but also those services that we can build, that we can go out into those other systems for individuals to get engaged. And then there are individuals that live on the third floor, and on the third floor are individuals that just don't have the insight into the need for treatment, aren't ready to accept treatment. And we have a different array of services for those individuals because we want to have contact with them and continue to provide them the hope of recovery, even though they're on the third floor. So Zach, if you'll move forward, I'll talk about the services. So on the first floor, as I mentioned, it was really important that we had a full continuum of care. And so you can see the kind of things that we built on the first floor. It went from, doing the outpatient counseling to making sure that we had things like specialized services for our women who are pregnant, services for our families to try and help engage their loved one, and an alternative youth group for our teens, a peer recovery center for our adults, just a full array of services. On the second floor, we really focused on the idea of not only like, how do we get that nudge? How do we go to them, as I mentioned? So that's where things like our drug court, our drug dependency court is. We have our mobile response and stabilization services where we go out. We developed recovery housing for men, for women, for our pregnant and women and postpartum women. So we develop services to work alongside child welfare, specialized services with our adult probation. But the idea is that as individuals interact with those other systems that are giving them a nudge, those other systems don't have to look far, because we're going to either bring the services out to them as a way to provide that outreach to get them to us, or once they get to us, we're going to try and have some more specialized care. Then on the third floor is really where we have been focusing our harm reduction services. We have syringe access services in our community. We have a quick response team. So anyone who experiences an overdose, we're making a visit to them to try and engage them. We are reviewing every overdose, every suicide in our community, once again, to try and take that information and then help inform what we need on the first floor, on the second floor, what we need in our prevention, and really trying to focus more and more on suicide as everybody's suicide numbers are going. So there's some things that cut across all floors, but hopefully you're getting the sense that there's a little increase in intensity between the floors. And on the third floor, our real goal is to always treat individuals with dignity and respect, even if they aren't ready for treatment. And no matter what floor individuals are on, we make any interaction wherever they are with whatever organization an opportunity for recovery. It's supposed to be an opportunity to open those doors. Zach, I'll let you move on. So when people ask me what it looks like, this picture is how I feel on a daily basis. As I mentioned, we try and get everyone involved. And the reason why we try and get everyone involved is that individuals that struggle with mental health or addiction, while they may go to a primary treatment agency or go into a hospital for withdrawal management or something like that, their recovery takes place where they live. It takes place where they work. It takes place where they recreate. It takes place where they work. And so it's very important that we're spreading the message and engaging all different parts of our community and giving them tools so that they know what they can do to not only recognize when somebody's in need of help, but also after they receive help to make sure that they're getting that support that helps them sustain and maintain their recovery. So, just by way of a few examples, with our faith-based community, we have an individual in our office who really focuses on that. And if you think of like TED Talks, we do FAM Talks, which are our faith, addiction, and mental health. And they happen once a month with leaders from all different churches, and we're just trying to expand their knowledge, make them more aware of the services that are available so that they can open their doors a little bit more. With the University of Findlay, we help them develop a certification program for addiction. So now they have a minor. So individuals at our university that get a degree in physical therapy, physician assistant, so on and so forth. Not only do they come out with that, but they come out with a minor in addictions. And individuals from the community can take it as a certificate program. And if they do, they come out with everything they need to apply for the CDCA credential in our state. I'm looking at time, so I'm going to keep moving us forward, but that's just a few examples. But we have something for everybody to do. Zach, if you'll move forward. So one of the pillars I talked about was the need to measure. With Dr. Flaherty's help, he's talked with us about you have to have 3 large measures. We have measures for everything. We have lots of things that we track, but we have a big measure for access, a big measure for retention, and a big measure for outcome. So the concept of access is that people can get in the door for treatment. The concept for retention is once we get them there, can we keep them? And then for outcome, we're tracking what's happening with our overdose deaths in our community. So you can see that we kept increasing our access to treatment over time, really peaked. And then with the pandemic, like so many others, there was a real retraction in the number of people coming into care. The blue line is of the people coming into care, the number coming in for opiate specific addiction. So that's where we are with access. Next slide, please. For getting people willing to stay in care, we're looking at the measure of people getting 90 days of consecutive care. One of the things that we were taught is if we can get that 90 days, that people have a much higher percent of getting to 6 months. And so our understanding is that the national average is about 20%. You can see on here that with our adult services, we're over 70%. And with our youth services, we're above 80%. One of the things our research partner shares with us, our researchers from Brandeis, is, in our community, if we can get people into care, we're likely to keep them there and then be able to have a more positive outcome. And by tracking this data, it's really helped our agencies really focus on that and the importance of keeping people engaged. Next slide, please. Then the last slide is to look at where we are in relationship to our overdose deaths. You can see on here that we are at the lowest that we've been since 2013. We had 10 overdose deaths in 2023, which is down almost 2/3 from 2022. So we just think it's a combination, it's a synergy of everything that's helping us move the needle on our overdose deaths. So just to quickly run through, when I look back over, we're now in our 11th year of our transformation. Just some quick lessons learned for you. Um, Again, the first one being don't lose sight of the vision. The vision is that everybody in your boundary becomes your we, and we want room for them, and we want them to have an opportunity for recovery at every interaction. I would say homework really matters when we're trying to convince people of things that we want to do. It's really hard for them to argue with the science, and there is a lot of science to support this approach. Uh, I mentioned that we collect a lot of data. We have measures from multiple systems, and we look at that every quarter. We share that with different members of our community. So as we're asking everybody to play a role, they can see the impact in other systems. I would say the more that you mobilize and include your recovery community, the more relevant and the more expedient you'll be able to make change. I would also share with you that change is not linear and that it's really important that you match needs with opportunities. And what I mean with that is sometimes we like to think, well, first we're going to do this, and then we're going to do this, and then we're going to do this. But what happens is all of a sudden a grant will become available for something that you weren't planning to do for 2 years down the road. So the approach we have taken is keep assessing our system, identify what our needs are, and then whenever there's an opportunity for resources, we try and address that resource with a need we have instead of thinking of it as a linear plan for implementation. There's nothing like partnering with a university. As I mentioned, partner with the University of Findlay, but Brandeis University has been a partner with us since the first grant that we got to help move us forward. And it has been a blessing in more ways than I can count, and maybe we can discuss after other people present. I also think it's important that people know that when you encounter barriers, which you will, just to be respectful and persistent. An example I can give you for that is withdrawal management. We tried for 7 years to get our hospital to do withdrawal management. We went to see, they were the very first stop when we started our transformation, because we're like, withdrawal management is it's the first sign in the door. It took us 7 years to get them to get services in place. And now I don't think they would ever get rid of it. But it took us going back year after year, sharing the science, sharing the need, and finally it happened. And then again, there's a role for everyone to be inclusive. And as I mentioned at the beginning, to always celebrate those moments and milestones so that you can keep everybody's energy up. So the real conclusion that I have come to after all of these years is that community is the cure. There is nothing that we are going to do for mental health and addiction alone. It's all of us together, and the definition of community is however you define your boundary. So with that, I think this is my contact information, and I know the slides will be shared with you. I'm going to flip things. Is Dr. Flaherty back on here now? Yes, I'm going to flip things back to Dr. Flaherty so that we'll go in that order.
Precia, I don't see that he's on.
I see him on there.
Do you?
Are you there, Dr. Flaherty? You're on mute. If you're muted, if you are.
There we go.
Yeah, you're still muted. You're still muted.
Hold
There
on.
you go.
There we go. Are we okay? Okay, great. Zach, you can take up the slides, please. And I apologize to everyone. I guess this is truly a webinar about recovery. And we are recovering from our planned process today. But I am Michael Flaherty, and I've been a privileged consultant to the project in Hancock and elsewhere around the country over the past 20-some years, with many of you that may be attending this today. But just wanted to express gratitude myself to the Great Lakes ATTC and all of the ATTC network for the great work they do as our Universities Without Walls in our field for mental health and substance use, and also to the team of people that you're about to meet over these three webinars. These three wonderful webinars where you're going to meet people who are going to share with you not textbook down applications, but experience up applications that they found helpful and working in their communities, as we say, planks for success. Next slide, please, Zach. What I hope to cover in my part of the presentation today are some of the basics. What is a ROSC? Why is it important? A few core definitions, how to build a ROSC, just as an introduction, and some of the things you see on the slide in front of you. I will mention briefly workforce harm reduction, overdose prevention, as Precia did. I'll go over some national studies and talk about prevention, but we'll have more of this in actually webinar 3, where we intend to enhance some of the other things that you see on the bottom of your slide. But before we go forward, I wanted to ask Alyssa, you can stay there, Zach, but if she would come in now, and just to get a sense for what you all know with our first poll question we had for the day of, how much do you really think you know what a ROSC is? So Alyssa, could you do that, please?
Yep, and Dr. Flaherty, we did get the answers to this when you're having some technical issues. So I'm sharing with everyone the results. Again, it was 29% of people of our group today are very familiar and work within ROSC. 11% are familiar but not working within ROSC. 36% were somewhat familiar, and 25% were not familiar.
Thank you. That's great. I hope we have the right composition of people in the audience. As one time I was giving the presentation, a gentleman came up and said, "This is so natural. It's in our genes. Why don't we all do it this way?" And we can go on from there. Zach, please, with the next slide. I still see the results.
You gotta press the X to close out of the results. Nope.
Okay. I don't see it. There we are. Okay. So there are some things I would like to set up, though, as sort of an a priori to the conversation as we proceed with the webinar. First is this statement that I personally would share with you, that the status quo approaches in our country today to substances and mental health issues, but particularly in substances, each year are not getting to where they need to go. We cannot arrest or treat our way out of the problem in our country. That's a premise that I personally would offer to you to think about. Can we treat ourselves or arrest ourselves out of this when you see all of the growing drug problems? I know we had a small diminishment this year, a significant one of deaths to overdose, but the numbers are still way too high and continuing so, particularly in young people. So we have tools, science, and knowledge to use today, but we have to go outside of our existing scope of work if we're going to truly get ahead of the challenges we have to stop these problems in our country, and that we have a will for it. I call this a community up approach, and it has recently been referred to as the sleeping giant solution by some sources I'll share with you later in the presentation to our substance problem in America. Go ahead, please, Zach. Question to each of you, where you are seated. Why do you do what you do? Think about that. Is it a job? Is it getting a person to come to treatment? Is it a person to get off drugs? Is it a person to have a better life? Is it a person to find recovery, relationships? This is so critical to sort of why we put our feet on the ground in the morning when we get up. Why do we say we're getting up and we have a good reason to get up today to do what we do? And that's a question I'd like to have you all at least ask today during the presentation. It's something I do every day. Next slide, please. So in our finding of that answer, we find purpose and leadership. And what we did in Hancock and other communities, we started out by getting to leaders. Precia first approached and asked, how will we build a better system of care? How can we put the continuum of care together? And the agreement was, if it had the purpose of recovery in it, we could do that together. That we just didn't want to have facilities and buildings. We wanted to have outcomes of recovery and health and wellness and population health. We managed health outcomes in that sense, and we'll talk more about this. We didn't want to just have treatment as usual, sometimes referred to as patchworks. We wanted to have really health and wellness established as our outcome. We wanted to effectively integrate that into all the community resources, not just the treatment or the criminal justice or the education or the clergy. We wanted all of it brought together, and we wanted to produce outcomes that matter to the people who live in the community. And while we were effectively building and measuring what we called, and many others refer to as recovery capital, or the resources that an individual, a family, or a community has to address their illnesses, their drug use, their mental health problems, their recovery capital. And we'll have a brief discussion about that. And promote continually population health. Why population health? Is because when you build recovery, you go right to the highest risk populations who reveal to you why the population health of the community is so stressed. Next slide, please. What is a ROSC? And many of you said that you knew, but some had not. And the key word here is a recovery-oriented system of care is a coordinated, and that's the key word, network of community services, all the services, as Precia outlined, the school, the health department, harm reduction efforts, the jail, the hospital, the recovery centers, everything that you can think of coming together with a common purpose, that to focus on the person, the family and the community, and to build the strengths and the resiliences of individuals, families in that community is what population health is and what a ROS builds. Recovery, I know some people will say to me on tour when I travel, oh, we need a better word, just call it systems of care. No, it can't be. Treatment as usual or topical care is not the same as recovery-oriented system of care. Recovery-oriented system of care has an intentionality in it to help the individual find that recovery as defined by many mechanisms, and we'll talk more about that. But in earlier, the community American Psychiatric Association in 2012, in an article said this is the model for the 21st century. It joins community with science and practice, bringing the community into the conversation. Next slide, please. There are 5 steps I'm going to share with you today to building your recovery model or your ROSC. This could be also said 5 planks for recovery success. The first one is to define recovery in your community. If you think this is easy, you're in for a challenge. This was the first step we began in Hancock County, and it was the array of answers to this were as broad as there were a number of people in the room. So defining recovery and then using that purpose and that conversation to bring everybody to a common understanding of what their community's values are and what the recovery is going to be defined as in their community. And that will change over time. You build and work within the recovery-oriented system of care, bringing your systems together, and then your recovery providers, your treatment agencies, focus in on recovery management, which I'll talk briefly about some new resources that have come up there that is just fantastic to teach people what's the difference between treatment as usual and recovery management. Involve the community and families, and all you do, as Precia said, measure and report back to committees that you've established to oversee this in the community, and measure your recovery capital and your population health, which is where the 21st century healthcare model is now, getting up public health models for population health. Next slide, please. Some of you may be from individual agencies and say, well, do we have to wait for a big systems change here? No, you don't. You can do it with singular in your agency through an additive process, where you just change your agency into recovery focus using recovery management, adding peers, warm handoffs, linkages, follow-up phone calls, and get into an agency-specific model for recovery. You can do it in a kind of line of service, which is what Michigan had done, where they practiced in their criminal justice system, turning it into a recovery-oriented system of care for criminal justice. And you can do a transformative model, which is the complete model that Hancock County did, where the culture was changed, the community education knowledge was elevated. You saw the floors of treatment that Precia outlined. All of that came as a result of her community sitting around tables with citizens and parents and those in recovery saying, this is what we need and want, and this is what we should do. Everything was viewed in the community through a lens of recovery. Next slide, please. Educate your community was step one, going out and reaching everyone, doing a recovery plan, setting down your goals. She mentioned, I think probably shockingly to some of you, she was now going into her 11th year. But honestly, a lot of those years were very progressive in the 3rd, 4th, and 5th year. She probably could have had some of this data if it weren't for the fact of COVID, and also the fact of this overdose epidemic that hit particularly Ohio during the time of this implementation. So she had two tsunamis, so to speak, that had to deal with that probably extended her data by about 4 years. So you could see that she may have done it much earlier. She disseminated her results constantly to her stakeholders, which were the recovering committee, the board of directors that she had, other special committees for young populations or housing, and each of them worked together, bringing the community together under her leadership. She had a group of 10 Ps, I'll show you in a second, that are critical. We've learned over these years in other application sites, if you don't have these 10 Ps in the room, you'll probably hit a stopping point somewhere because one inadvertently or by conscious design may stop you. But you need to have them as well as your ROSC leadership, your people in recovery. And it's interesting to note that just as they were picking a jury yesterday for Hunter Biden's trial, they asked the 50 attending jurors how many had experience with substance use in their life, and all 50 raised their hands. So this is the depth of what we're dealing with in this country. Analyze system strengths and weaknesses. She did that with ASAM guidance. I'll talk more about that. But you want to have a good system pattern. So you want people who are identified to have an opportunity for good care. That's the best science comes into practice, which comes into community. And you draft a preamble for care, which I could share with you if you're interested. It basically is a statement, a 2-page philosophy that says this is what we will do in our community, in our county, and all of the providers signed on to it, as well as the agencies. And later, by the way, when other providers tried to come into the county for different reasons, perhaps just for profit, they could not sign those documents, and that was a real interesting point for them because they at some point decided not to come into the county. Set up your initial goals and measures and move forward. Step 2 in your implementation of your planks. Next slide. These are the 10 Ps that you should have. You need one of these involved at some level in the communication of your ROSC. As I said, if you don't, they can come in and ask, what are you doing and why am I not there? And of course, it's providers, people in recovery, the general public also, are your top, the parents, family members. Your funders, your foundations are there, particularly for your early initiatives. You want to have them so you can prove something is working. Your United Way and other foundations that could come in and say, hey, we help prove that this works. Let's take it into our general funding stream now. Other payers, public and private, would come next. That's your Department of Welfare, Health, Medicare, your public health systems. The police, absolutely. Your first responders, your quick response team, as Precia noted, the press and the press are important not just to be neutral reporters of what's going on, but the fact that they are, for so many people, the communicator of what's happening in the community and what knowledge people get from about the illness and the stigma come from the press. Pastors and clergy, we have a common mission there of bringing people to change for the better, and they work, and they've been fantastic assets in Hancock County. Universities, as she mentioned, researchers, and we'll talk more about that. And of course, last but certainly not least, is the policymakers. Your mayor, your city council people, you have to be informed, and this becomes quickly a campaigning strategy if somebody decides they want to do it and understands it. And it's one quick way to move ahead. Next slide, please. What Precia did initially is she opened up the ASAM criteria book. We showed her the importance of patient matching, which is so critical that people go through the right door, or at least as best we can attain. That's your best science. And then they go to the level of care that they can be best addressed by, not just one port, one door. This is what she did. She, at the same point of implementing ROSC philosophy, she built a system around it of providers and service agencies, so that somewhere there was a continuum item for every single level of care, even if it meant going outside of her county and into other counties, but having service agreements when she needed, say, something as for withdrawal management or rehab. She could do that through even her agreements in her county. Next slide, please. So you define recovery for all, and this is SAMHSA's current definition. Won't spend too much time here, but it's important to note that, you know, it doesn't say abstinence, which it first did 20 years ago when we started. It has other measures, health, home, purpose, and community, and a self-directed life. These are important philosophical and intentionality statements that we want to keep in ROSC. That's all about the individual and the person first, and the family. Next slide, please. Step 3, recovery becomes an overarching unifying construct for all care. Again, as some people say, recovery is the wrong word. It could be health and wellness. Well, that's general and broader than recovery. And we're all in some form of recovery if we care to stop for a second and think about it. Even if it's just to have a better day. Bring community together and its services, unite together in this common effort, this wellness and recovery belief across all systems, that this is what you want employers to think about their community, or why to bring your business to your county or area, is because this is a community that values its populations. Key here, as Precia did note, is that there's an opportunity for recovery in every level, every episode, and every stage of care, that there's an awareness that if you can only provide a certain level, say outpatient, and the person needs a stronger level of care, a higher level of care, it's still in the continuum of care that seeks recovery of a disease that potentially could be a chronic disease. And I added CBT-R. The bottom of that slide, something with Aaron Beck and I, we presented at the American Psychological Association in 2012. And he said this is the breakthrough that he was waiting for with cognitive behavioral therapy, which addresses distortions. And the distortions were leaving people in substance abuse locked into their distortions. I am an addict. I am a person who can't quit. I'm a person who can't get out of this. Those are distortive thinkings, even though they're sober. But then recovery comes in, and the recovery measures you're about to see are ways that they led them out of their cognitive distortions. Next slide. These are the measures that lead people out of their locked world or their addictive state of being. Of course, their alcohol and drug use, which ideally could be abstinence, but it's progressive. It could be on medication. And there were books written by William White and Sandra Torres and others about using medications and recovery, and how to manage it once it's stabilized, and how a person can attain recovery once stabilized in medication. Better living environments, better physical health, better emotional health, family health. These are the measures that take people out of their distorted or stigmatized or believed way of being into a better way of being and a citizenship and a quality of life and meaning and purpose. And by the way, these are all embedded in the National Behavioral Health Quality Framework, which for those of you who say, well, what's that? That's the agency that defines the block grants to the states. And in each block grant to the states, it now says that you can use these measures and you can alter your system to a recovery model using your block grant if you can find the resources to do so. Next slide, please. Okay, agency recovery measures. I put these in just for an example of our executive aides from agencies saying, well, what do we need to measure ourselves if you're recovery focused? Of course, treatment attraction and access. Are you using brief screens earlier and matching people accordingly, including, medicated assisted treatment? Hancock County has about 56% of its people now on who opiate use disorder into medicated assisted treatment, which is phenomenal. The national average is much lower. Quality of services team, do you have the right people? That's a tough one with our workforce challenges today. Service relationships, you can measure that people are retained in treatment, getting the NIDA suggested 90 days minimal. Assertive linkages using warm peer handoffs and peers and following up are proving extraordinarily valuable. And post-treatment monitoring, supporting an early re-intervention if needed, is also been proven quite effective in keeping costs and lives going. Next slide, please. Stage 4, measuring and reporting all of this back to your community. You access, retention, and outcomes are the 3 key measures that you want to measure, as you did in Hancock, but everyone else is doing. Are you improving access to care? Numbers going up. Are you keeping them or providing the right dose of care for retention, with a substance use diagnosis or a mental health severe diagnosis? 90 days seems to be minimal. And then your outcomes, and you can define your outcomes based on what you think you need. What she found is, and I'll share with you in a minute, reduction of acute care ER visits, reduction in waiting lists, reduction in deaths, overdose deaths she shared, and reduction in social costs in her community while she was building measurable recovery capital. So if somebody went into recovery, they gained recovery capital, and the community recovery itself went up at the same time. Next slide. This is one of my most interesting points of learning about the Ross model and how it defines prevention. Probably nothing is as important in the Ross model than prevention, but what it does is it puts applied prevention into force. So as you understand a person gets well, what it took and who it was that needed that, you go back and build your prevention model based on what is actually needed in the community, whether it's selected, indicated, universal, but you look at what it is real to the community and define your prevention from that, as opposed to, say, textbook down, defining prevention in a more broader way without knowing exactly what the needs are in the community. That's what we mean by applied prevention in Ross, and it really is a vital element, and this would be step 5 of our 5 planks. Next slide, please. These are 2 documents that came out actually in the last 6 months, TIP 64, TIP 65. I highly recommend to you. They're wonderful. TIP 65 really is the best document I've seen to date on covering recovery management and all of the practices of counselors in recovery, working in recovery, agencies in recovery, everybody working within a ROSC. It's a fantastic document. TIP 64 is its sister document, and it goes to peers and working with peers and how peers can be expanding and help us in our workforce development. 2 wonderful resources I would hope you would all check out. Next slide. But does all this work? And we'll go through some of this very briefly, and again, the sense of time. But I've been doing this a while, and I have lots of data, both nationally and locally, in fact, even internationally. The Connecticut experience with Tom Kirk and others, where they changed the state level model, taking 90,000 patients annually, used ROSC to the warm handoffs, connectivity, patient matching, and were able to reduce by 62% the use of the acute care in their state. They were also to increase with that resource ambulatory or outpatient care by 78%. So they lowered the severity significantly with an overall 14% reduction in the system cost, even while they added to it a 24% increase in services through housing and recovery homes, etc. So they broadened their service development just using the recovery model, and we'll explain more about how that worked in Connecticut. Next slide, please. Michigan, I mentioned, did it through their criminal justice system, and Terry Klein, former head of SAMHSA, did that years ago in 2008, and he built a recovery model in the recovery system there and found out that it stopped the revolving door between incarceration and community. How? Through peers, through connectivity, through entering into the prison system with the level of care that people incarcerated needed, which most of what ROSC uncovers is that it does eventually become a in jail or in-house incarceration is a wonderful place to begin your recovery model. Next slide, please. Access to recovery, 190,000 people were studied in this case study, and you can see they had 73% reduction of individuals reporting substance use at discharge. 23% of those reporting not having stable housing had it at discharge. 30% more were employed. 62% found positive. Most of this can be attributed to one thing: the human relationships, the caring and connectivity of human relationships in a broader way rather than the matriculation of people through a sort of standard treatment as usual stigmatized system. Next slide. This is the recovery management study done internationally in 6 countries, and they found increases in these particular values across these 6 countries in 16 dominant areas of practice. And you can see these at your own leisure, but it's just about everything we would want to have as good therapists, counselors in our work and field: improving health, improving hopefulness, feeling strength, that adding empowerment to the individual. And the citation is there also. Next slide, please. Clinical outcome study of 4 years done on reintervention. This was Christy Scott and Mike Dennis at Chestnut Health, and they had done this study saying that they too found positive outcomes over their 4 years studied in improving clinical outcomes based on reductions in use using the model, reduced healthcare and personnel problems, and reduced further acute care costs. So again, one more study. Next slide, please. Philadelphia changed their whole system to this approach not too many years ago, and they found the same, that the system needed to be changed. So they had earlier engagement, added peer supports, did more holistic assessments rather than just looking at severity of illness. They began to look at recovery measures and what was missing from a person's more positive life. The role of the client was to be empowered, etc. And Philadelphia, next slide, please. I found also they actually got 2 slides. They deserve so much for what they've done in the Philadelphia community, which is different than what Precia had done, by the way. Philadelphia, it eventually morphed into a system of those in recovery and those in treatment, whereas Precia was a transformative model where the whole community went into transforming itself into a recovery focus in everything they did. So, and one's a county, one's a major metropolitan city. So all of that has to be considered for those of you that may be thinking about where and how to do this. Next slide. Cost, everybody wants to know, is this going to be cost effective? Years ago, not too many years ago, Gary Zarkin had done a study with his team and found out that using the model of a chronic illness, potentially making sure the person is kept into recognition and treatment for a standard dose of time, with follow-up support, reduced almost $32 from the cost of treatment for every dollar spent in standard treatment as usual. So it was moving the understanding of addiction from an acute illness to a chronic illness, and then studying the effects of treating that through a chronic approach, which is what ROSC itself does also. So the comparative of that data was a 32-to-1 savings. Next slide, please. Over time, that over the number of reoccurrences. Recently, some current thoughts in the last year that I've been able to come across in our work in different parts of the country. ROSC joins with science to state that it's the 21st century medical model, and that was from the American Psychiatric Association, 2012. ASAM, American Society of Addiction Medicine, and New York Times both refer to ROSC in different articles, describe recovery as the sleeping giant solution to America's drug problem, which of course is community up solutions taking hold and building together. SAMHSA published these wonderful documents I mentioned, TIP 65 and TIP 64, and Associated Press recently visited Hancock in November. There's a lot of stir right now in the country about, are the opiate settlement funds being used properly? Lawsuits are being filed where they aren't. Well, in this particular case, there's a SWAT team in the Associated Press who travels nationally to see if they are being spent appropriately. And their finding was in Hancock County, as billions rolled out to fight the U.S. opiate epidemic, one county is showing how recovery can work. And that article is certainly available if you want to read it, but they were convinced Hancock was doing it right. Next slide. You've already heard from Precia, so I'm not going to go ask her to come back, but can we go to the next slide? Zach, please. I want to show the group some of her outcomes statistically, or some of her data, which is she's found over these years a 42% increase in access from her system when it started to today, a 62% increase in Hancock and those starting or attaining a 90-day length of treatment. She mentioned the standard was 20%. It's actually below that. Think about what the number of people in your community who are on substance use or even mental health. How many are getting a 90-day continuum? 54% of those on opiates are now on MAT in Hancock. It was a real struggle to get new medications, new providers to change minds and thoughts. 57% are now getting warm Hancocks off at every level of care. 103 ER admissions in 2019, 66 in 23, and the overdose deaths down, 2/3. Triple utilization in her recovery center, which is now bulging at the seams, looking for new places to go. She's developed new programs for a mom's project for veterans you're going to hear about this afternoon, the recovery homes, different things, peers development through the university, career chains, really a complete community adopting and embracing recovery. And the average of 28 people who provide almost 1,698 hours of volunteer recovery peer support. Peer supports are, most of them are not paid as such. Some are, if they're employed by agencies, so that's often a question, but most are not. But it's something that certainly is worth being paid for, and I follow that nationally and quite a bit in my work with the Annapolis Coalition. Next slide, please. I think that's about it. We've already covered this in the data I gave her, but these are the planks that Precia found, the numbers that were just supported, that she empowered her community, she reduced the cost to her system, she increased the number of people who now have recovery capital, assets in the community, strengthened the community. Industry has supported her for that reason. She's reduced overdose dramatically in Hancock, reduction of jail. She has services in the jail now, crime. Workforce has been a real challenge today, and we still have to tackle that. But system coordination, the community adoption of the Ross philosophy, and actually the empowerment of feeling like they are doing something about population health and wellness in the community of Hancock County. I think that's about it now. Is next, yeah, there are your citations. If anybody has any questions, I'm happy to take them, or we can do them at the end. I know it's a lot of data, but you can have the slides. And I think, Alyssa, is there another poll, or did you get that one done also?
No, we have not done the Mentimeter yet. Zach, would you like me to bring that up?
Yeah, you can go ahead and do that.
And if there are questions, just put them in the chat and I'll be happy to answer them. But we have two more speakers we want to get to today.
So Jen did put the link in the chat for everyone to access the Mentimeter. If you could, the question that pops up should be, who should be involved from the community to help create and / enhance a ROSC?
I think we'll give just a few more moments for people to type in their thoughts. Well, great. Since I don't see much more changing with that, I appreciate everyone's taking the time to do that. I will switch screens here just a moment. And I appreciate the opportunity to speak with you today. I'm going to talk just a little bit about how our community really has been bracing this sense of collaboration at not just the service provider level and not just at the systems development level, but really at the entire community level. One of the things that I think has been a success and has allowed success to happen with ROSC is that we really have this sense of community collaboration, this sense of collective impact that's actually been around in our community for almost 35 years now. My next slide here is going to demonstrate just briefly some of those collaborative efforts that are happening in the community. I mentioned, 35 years of collaborative work. Actually, in 1990, Precia was the co-author of a grant to the federal government to establish our Hancock County Community Partnership. And that is a systems-based or sectors-based entity, coalition, if you will, that really focuses on prevention, and at the time, substance use prevention specifically. But it really required different entities, organizations, systems to be represented around the table to try to really find community solutions to issues. And so, for 35 years, we've been in the spirit of working collaboratively, and that coalition continues to exist. And you'll see a couple of examples of outputs of that. 20 years later, we recognized in the community that we had an issue coming around the bend with prescription misuse, opiate misuse. And so actually at a community medication collection, there was a decision to rally around this issue and to create another coalition focused specifically on the upcoming foreseeable issue related to opiates and addiction. Initially, that coalition was focused on just the opiate and medication issue, but as we started to get into ROSC, we recognized that there are a number of things that needed to be addressed collaboratively through the community, and that is why they changed themselves to focus specific on all addictions as it relates to those issues. When we started ROSC, we needed to have a way for the people that are making the decisions for those systems changes to be involved in decision-making and discussions and collaboration. And so a ROSC leadership committee was established to help kind of move that work forward, and also to have the communication filtered down, not only from the leadership, but all the way to the people that are delivering those services out in the field. That community, that leadership committee continues to meet on a regular basis to really kind of talk about, what are we seeing that's needed that we haven't yet done as we've transformed in ROSC. What's interesting about the next circle, the delegation that started in 2016, what the delegation does, if you think about your cultural awareness, your cultural humility, creating those spaces of belonging and understanding that Precia mentioned about in her discussion, all of that work really is centering and coming out of the delegation. And I always like to share a story about how the delegation started. In 2015, it was actually a committee member or a committee chair of the County Coalition on Addiction came to the beginning of a meeting and said, when we do this outreach work, when we go and have these town halls, when we have these meetings where we're trying to share the information, a couple of things are happening. One, I don't see anyone that looks like me coming to these meetings because clearly there is a particular population that I represent that does not come to these meetings. And she also shared a very sad story of someone who had their grandson pass away from an overdose. because the resources that we were currently providing at that time were not in a language that was accessible for that person that needed to know that Narcan or naloxone was available in the community. So at that time, we decided, why don't we just start by translating our resources into Spanish? And so we did that. And as we were doing that in that process, we took that to Dr. Flaherty, and Dr. Flaherty said, you know, this is much bigger than just talking about translating resources. This really speaks to the spirit of what ROSC is about. It speaks to the idea of embracing everyone around the table, that they all have a voice, and they all have to become empowered to make those changes in the community. And so the delegation is taking that spirit, and you'll see in the next couple of slides some of the outputs of the delegation that really focuses on that. Just recently, out of the ROSC Leadership Committee, there was a desire to focus more on suicide prevention. And sadly, that's because we've been seeing an increase in our suicide fatalities in our community. But knowing that those tragic events inform the work that we need to do in the community in prevention, there has been a very dedicated group of folks that have been coming to the table on a regular basis to talk about how do we frame suicide prevention in the community and within the context of ROSC. And then finally, as Precia had talked about workforce challenges, and Dr. Flaherty mentioned those as well, we have been embracing the Surgeon General's report as it relates to mental health in the workforce. And how are we also taking care of the people that are delivering the services? And how are we, one, attracting them to come to the field to deliver those services? How are we encouraging them to stay? What incentives, what ways, those non-traditional ways, perhaps, that we're trying to keep them delivering the services, whether it's in the same agency or at least within the community? And how are we advancing the workforce field at an educational level so that our younger folks that may have an aptitude or an interest in mental health or substance use have a career pathway that helps them become successful in the field? All of those organizations or entities, collaborative pieces, I wanted to kind of just show visually that they're all framed and all rooted in ROSC. Even our community partnership, which started back in 1990, is rooted in ROSC as it thinks about what are we learning from our overdose fatality reviews to inform the prevention work that we're investing in, that we're advancing at a level that we've never done before, as a way to really think about what does recovery look like. Dr. Flaherty had mentioned earlier that there are the 10 Ps in the community. And I wanted to just provide an overlay of what the 10 Ps in ROSC look like within coalition work. And that's the circle that's on the right. Interestingly, these sectors are rooted in coalition science, particularly what we learned from CADCA, which is the Community Anti-Drug Coalitions of America, which I'm sure many of you are familiar is kind of our national technical assistance organization that helps coalitions that are focused on prevention, substance use prevention, ensure that there are those voices around the table. But you can see, although they have different names or different labels, it's kind of the same group of folks. And what's interesting about our sector circle is that through our work with the community partnership and through ROSC, we have added 2 additional sectors that you won't necessarily see when CADCA lists their sectors. That includes young adults, 18 to 25-year-olds. We learned in our work through a SPIF project, a strategic prevention framework project, we're focusing on prescription medication misuse, that we really wanted to focus on not only collegiate level, but the 18 to 25-year-olds who are either transient in the sense that they're coming to the community to be employed, they did not go to college, maybe they aren't employed, they've just graduated from high school, but it's a very unique perspective that's also important for us to think about. And often we think about young adults as collegiates or professionals, but we don't think about them, maybe the folks that are working in the manufacturing organizations that are working, very technical, skilled-based labor jobs, and their voice is important as well. The other sector that we absolutely included around the prevention table is the recovery peer voice. And so we added a seat for that voice to be at the table. what's interesting, I wanted to share, you know, in our community, of all these sectors, of all those collaborative groups that I've mentioned, we have a roster of over 230 people in the community that are engaged in some way across these and around these tables, from the partnership to the ROSC leadership team to the delegation. And not only is it that many people, but that's representing about 65 organizations in our community. So to say that, you know, we have people represented around the table is an understatement, because we really do have a number of people that, you know, and a number of them are maybe they just want to be informed. They want to learn about what's happening, so they're on the mailing list. You know, there are a number of them that cross different groups that are involved in multiple ways. But the one thing that we always make sure to let people know is that if they have an interest, a desire to be involved, we will find a place for them to be engaged in that conversation, whether it's in the partnership, whether it's in the community, a coalition on addiction. There is a way for them to be involved in the collaborative process. What does that collaborative process look like? Well, we have 3 areas of focus that we really want to emphasize in all of this work. We certainly want to continue to improve, expand, deepen our services and supports. But we also want to make sure that the language we're using is grounded in that ROSC framework. Person first, recovery oriented, making sure that the language we use is not stigmatizing, making sure that it's welcoming and it creates spaces of belonging. And most importantly, we want to ensure that our policies that also govern our organizations, govern our practices, governing our programs are all rooted in that concept of recovery-oriented system of care. And so as we work in the partnership, we work in the coalition on addiction, we want to make sure kind of are all of these 3 areas of focus some way, some part of this work. I wanted to give you some tangibles of those outcomes or those outputs that we've been doing in those 3 areas of focus. In the language area, what has been really transformative and pretty remarkable in our community is how our headlines and our local newspaper and news outlets has changed. When we were early in our ROS development and we were working on establishing some recovery homes, it was met with quite a bit of resistance. And we had headlines in the newspaper that said things like, Adamus Board is opening up a home for addicts. People they were very derogatory headlines related to the work we were trying to accomplish by creating that sense of dignity and humanity for people that are struggling with substance use. Fast forward 12 years, we now have headlines that say, focus, recovery, and wellness communities see success. Recovery homes have, yielded positive results. So we have been able to change those headlines because we had the press and the paper and the people that work in the news around those tables, so that they were educated, they became understanding about the work we're trying to do. And that really has changed the way people have thought about recovery in our community. Also in the language, creating spaces of belonging. One of the tenets that the delegation, which focuses on this, utilizes is the work of John Powell out of the Othering and Belonging Institute out of Berkeley, California. And he often shows a diagram of 3 circles. One circle has little circles inside that are all the same color, but outside the circle is a small group of multicolored circles. And he calls that as othering. And I think that's very understandable. The majority has the power and is excluding everyone else. The second part of the diagram includes those multicolored circles within the larger circle. However, although that's inclusive, John says that it's not fully embracing belonging because the majority still has the power. And a way to think about this is, in the first circle, we're going to have a party, but you're not invited. In the second party, that's inclusion, we're going to have a party, but we've already selected the song list and the menu. The third one is where all of those multicolored circles are integrated and actually expanding outside of the boundaries. And that is true belonging. And the phrase to think about that is, hey, we're going to create a party. We want you to help us. We want to build it together. We want to create the menu together, the song list together, and even the decorations. And so the delegation using that collective voice power has really helped to move along those creating those spaces of belonging. The other area in language I wanted to point out is we've been partnering with the Addiction Policy Forum and participating in an anti-stigma initiative. One of the tenets of our Coalition on Addiction is reducing stigma as it relates to recovery, as it relates to substance use and mental health. And so we had a small group of folks go through a training to learn about a curriculum that's focusing on anti-stigma, which we will deliver later this month to through one of our local agencies' educational opportunities. And it also included a survey. We had about 100 of our community members respond to a survey about their attitudes, perceptions, beliefs as it relates to stigma and relates to substance use. And so we're going to use that data when it becomes available to us to inform our programs, practices, policies, and language moving forward. In the services and supports area, Dr. Flaherty spoke quite a bit about informed prevention. And what I want to highlight here is when we were doing our overdose fatality reviews, we recognized that there is aftermath in the sense that there are people left behind, particularly young people, particularly youth. They may have had a parent that died from an overdose. They may have had a sibling, an older sibling, an aunt and uncle. But nonetheless, they have been tremendously impacted by addiction. And so with a number of partners, Hancock County developed what is called Hancock our Camp Fun. And it truly is just an opportunity that happens twice a year for kids who, however they have been impacted by addiction, have an opportunity to come together. They have an unknown shared experience in the sense that it's not said you're coming here because you've had this experience, but it gives them a way to build that pro-social bonding, to have an opportunity to just be a kid and be fun. This year, we're actually in a couple of weeks going to have, I think, our 6th iteration of that camp, and it continues to grow. We have over 35 kids that have signed up for that, so we're excited about that. One other output as it relates to services and supports is our Recovery Resources Guide. This is a 35-page document that goes from what is addiction, what are the warning signs to look for when it relates to substance misuse and substance use? Where can people access care and treatment? Where can people access recovery supports? And this document goes through every coalition, every committee for review to make sure that everything is included that's correct. Is there things that are no longer relevant? Are there things we need to add? This year, we've added a few things about maternal opiate health, maternal mental health, and also suicide awareness signs of suicide ideation. So it continues to evolve, but it has become a wonderful document. And I will tell you a story I like to share about this document is there's a coffee shop downtown, and I attend frequently, and often I'll be looking out the window. And one particular day, there was a gentleman who walked by and sat outside the window. All he had with him was a book bag, and it was a very thin book bag. And most likely, this gentleman had just left the city mission, our homeless shelter. He had sat down and he pulled out the Recovery Resources Guide out of his bag. Because this is used so widely across our community, and it's a very powerful resource that anyone has access to. Also, in our services and supports, I wanted to point out that we also want to reinforce the opportunity for recovery enhancements, additional recovery supports that may be not as traditional as your groups or going to a recovery center, and that is through the use of technology. And so we have been able to use grant funds provided by our state to provide free of charge the e-recovery app, which is through Chess Health, as another treatment enhancer for people to use. For those moments between they go to group or they go to and talk to the therapist, that's where the real recovery is happening. And it's another way for them to connect with people when they're in between those opportunities. And so we are really excited to be able to continue to share that. On the policy side, we did this early on through our ROSC leadership team. Our committee was, we established a protocol as it relates to medication-assisted treatment. And essentially it says that if you are going to deliver MAT services in our community, we would encourage you to sign off on this protocol saying that you work collaboratively with us and that you're going to provide not only talking about MAT, but also reinforcing all of these other services and supports that are available in the community. And it's a way that, no matter where someone is trying to enter recovery in the community, there is consistency, there is collaboration. And so we're very proud of that MAT protocol, which again goes through revision on a regular basis to make sure we're bringing in the latest science, we're bringing in the latest tools that are available for our community in that. Also related to policy is the inclusion toolkit. This is a product of our delegation, again, which is focusing on spaces of belonging and equity. What we wanted to do was to make sure that particularly our behavioral health providers knew that they were adequately and effectively not only supporting the people that they serve, but also themselves as an organization and creating policies that are inclusive. And so the toolkit looks at things like, are the policies written in a way that are not excluding unintentionally other members of their organization? Are they intentionally including people that they're serving? Are they adequately and appropriately collecting data to inform them of the people that they're serving? And how are they then embracing that work across the enterprise or across the organization? So we partnered with an organization out of Perrysburg, Ohio. We commissioned, it was never created before. It is a toolkit that it talks about all of those areas, and we're getting ready to launch the training. We're going to have the first pilot training coming up on the 18th to get a feel for how the delegation responds to that. And we're excited then to be able to present that to some very focused groups. We're going to present it to our business community, our nonprofit community, and also our school community. And I wanted to close my portion with talking about policy, and it relates to guiding principles. We ground all of our work clearly in the ROSC formula. We ground our work in those principles, but we also ground the work of our coalitions in those principles as well. And our Coalition on Addiction has 4 principles that they do all their work through. The first one is that the coalition wants to ensure that we are supporting people with substance use disorder and their loved ones, supporting them however that is necessary, and have the families however they defined it. We want to support accessibility and reduce barriers to services. All of this, again, is reflective of what Precia shared and Dr. Flaherty shared. We also want to implement the best prevention strategies that impact people with the highest risk. That speaks to the idea if we're really supporting the people that have the highest need. Dr. Flaherty shares with us that when you lift the tide for one, you lift the tide for all. And so it's important that we're thinking about whatever we're doing for the people with the highest needs certainly supports everyone. And also reducing stigma. And I'll close with the values of the coalition, and they are that every life is valued and every member of the community is vital to the work of the coalition. So we have a fantastic history of collaborative work, and we're excited now to root all of that in the sense of ROSC. So with that, I think I'm going to turn it over to Nichole, unless there are any questions in the Q&A that need to be answered.
Thank you very much, Zach. So my name is Nichole Coleman, and I am the Executive Director at the Hancock County Veterans Service Office. And as the previous presenters mentioned, I have been with ROSC since it started. And I went to work in the Veterans Service Office in our county in 2011. So I was still pretty new in this type of professional atmosphere. So I was a little surprised to be invited to the table until I learned what ROSC was all about. And then I was all in. Next slide, please, Zach. So I'm going to talk about the way my office looks at ROSC is how do we develop healthy behaviors, thoughts, and actions among our staff? And then how do we help our clients do the same thing? And our clients are veterans, their spouses, their surviving spouses, and their families. Next slide, please. So we will talk about the definition of resilience and why that was the word that we chose to use in the Veterans Service Office. It was very intentional. What are the resiliency programs that have been developed as a result of what I personally learned from sitting at the table at ROSC? A little bit about our veteran empowerment fairs, and what I think might be maybe most important for several of the people in this room is, how did I get staff buy-in? Because so oftentimes when we learn of something new or we hear a great idea and we want to implement it, we have to get the buy-in of the people who are going to help us implement those changes. So I will talk a little bit about that. So I'm going to tell you about my story and how ROSC, how me being invited to this table impacted my personal recovery. So on the screen right now, you see a picture of my husband and I, and that was our honeymoon at the first Gulf War in Saudi Arabia. And on the screen, you also see two of my uncles, my dad, my aunt, and one of my grandfathers. I have a long line of military heritage in my family that I am very proud of, and I was proud to continue that heritage. Through that, I have come to learn a lot about how does military service impact our lives following service, where might we experience trauma, how does the military teach us to respond to that trauma? And then how do we reintegrate into civilian life following that trauma? And what I want to talk about a little bit in this specific slide is how when I was invited to come to this table and I was in the room, I thought, I don't belong in this space. The people in this room are mental health professionals, they are medical professionals, and I don't have any of this kind of experience, any of this kind of background. And the first meeting, at the very beginning, I didn't even understand a lot of what was being discussed. But you heard from Precia at the very beginning and how she reframes things. That's the way she puts it. And she really does. She reframes things so that anyone can understand it. And so I think one of the takeaways that I hope everyone gets is, while it is incredibly important to invite these other parties to the table, it's equally important that you make sure that they feel valued and that they understand what is being presented in these meetings and how it applies to who they are, the experience that they bring to the table, and how collaboratively you can make a difference. The other thing that Precia said was, there are times when we are the helper and there are times when we need help. And about a year before I was invited to join ROSC, I had received a few mental health diagnoses. And I was managing that by self-medicating with alcohol and not realizing how that was impacting my life. And as I sat around the table at ROSC, I heard a lot of information that I could apply in my own life to make positive changes. And as I heard that information, I got the sense that the professionals around the table would still feel the same way about me if I asked questions that helped myself as well as my clients. So I tested that theory and asked a question. And what I found the very first time was that there were no facial expressions that made me feel less than. There was no body language of shock. And I was treated exactly the same when people saw me in the community following that meeting. And so that was the philosophy, or the kind of the attitude that I came to these meetings with every single time. I was going to find information that would help me personally, and in the process, learn everything I could to equip my team to have a positive impact on the clients that we were seeing, and to bring that information back to the table at ROSC. Next slide, please. So I'm not going to talk a lot about a few of these slides. This is one of them. I wanted this information to be included just in case there was anyone in this presentation who was not aware of the impact of the trauma that veterans face during their time in service, and the growing risk of suicide. So that will be there for you to refer to later. Next slide, please. Oh, I forgot there were several things there. Thank you, Zach. That's okay. Keep going. And this one is another one that I just want to provide briefly. And that is, what is the percentage of veterans who have been deployed? What is their risk of each of these things? Are they going to experience PTSD, depression, traumatic brain injury, feeling those outbursts of sudden anger? And this provides you some good information about that as well. Next slide, please. So why did we use the word resilience, and what is resilience not? Resilience is not a medical system, and it's not a behavioral treatment system. Resiliency is built by working with veterans to enhance skills and increase confidence and support and supportive relationships. So that was kind of the foundation of everything that we did in my office. Once we started gaining this knowledge and information about ROSC, was how can we equip and empower our veterans to have the confidence and the support that they need to live their best life. Next slide, please. And we looked at, what is the VA doing? So as the County Veteran Service Office, we are county employees. We are not employed by the VA, but we do collaborate very closely with the VA. So we looked at what are they doing, and saw this circle of health on the VA's website, and really began to dive into this. And we found some similar, some tools that we could use from the SAMHSA website that would help us walk through some assessments with our veterans to help them discover maybe which part of this circle of health they needed to address first. Was it food and drink? Maybe, they're not fueling their bodies accurately, or was it moving the body? They're not exercising or doing things that energize them. So we looked at this, and we made this circle of health, again, another cornerstone of how we were implementing the ROSC changes in the Veteran Service Office and those that we are serving. Next slide, please. So as we began as a staff talking about how are we going to implement ROSC, we were looking at what are the words or the verbiage that we would like to use within our staff. And then if we're going to communicate findings out to our clients, what is the word or the verbiage that we want to use? And we came up with resilience because resilience is something that is that is language that is used in the military over and over again. But I also wanted to understand from a psychology standpoint, what is the definition of resilience? And I'm not going to read that to you because you, again, will have these slides, but just wanted you to understand that from the military perspective, there is value, and I'm going to explain that in the next slide. And from a psychologist or mental health side, There is a lot of foundation to it as well. Next slide, please. So how does the Army use the word resilient? And so they use it as the Army R2. That means that you are ready and resilient. And that means that you have the ability to persevere, adapt, and grow in dynamic or stressful environments. And so again, this is at the core of everything when we are meeting with our clients or when we are developing programs. We are assessing, is this going to help our clients persevere, adapt, and grow in stressful situations? Zach, if you'll go forward, I believe 2 slides. Perfect. I put this on here maybe just as a reminder to everyone in this session to reach out to the veterans. You know, there are some specific times when it's extra hard for veterans. This time of year is one of those around Memorial Day. If they have lost loved ones in battle, this is a time that will be very sad and difficult for them. And around Veterans Day and around the holidays, so between Thanksgiving and Christmas, that is another time that's really difficult. And I know that in the mental health space, that's a difficult time for everyone. So finding ways for you as professionals to check on the veterans, you know, whether they be professionals that you work with or clients of yours, and then reminding your community in your social media or similar places to check on the veterans that you know. Next slide, please. So I'm going to now talk about some of the events or some of the programs that we have come up with. And one of them is our Veterans Empowerment Fairs. And this is something we do 4 times a year where we bring in mental health professionals, financial advisors, physical therapists, all different types of resources from our community, and feed them and give them an opportunity to collaborate with those professionals, as well as get together with veterans from our community that they may not know. Next slide. Now, the rest of these programs that I'm going to tell you about, or at least the next 4, are programs that were started at the beginning of this. I told you a little bit about how when I was sitting around the table, I noticed things that I could do to better my own life and recognized a need for recovery in my own life. And so these next 4 programs, or at least 3 of them, are programs that were started because they were things that helped me, and now they are helping hundreds of other veterans. So Veterans Discovering New Life, if you'll remember on that circle of wellness, one of the things that is on that circle is spirituality, or finding meaning, finding a source bigger than yourself. And that was something that I have leaned on very heavily. So I started a group that is a faith-based group, has a faith component to it, where veterans can gather, and there is no religion discussed. It is just a place where veterans can talk about faith if that is a part of their recovery. And we also have some who are not in the faith community at all, who still come and really gain a lot. So we have about 40, I think about 45 veterans who receive a weekly text from me in reference to this program. And we have about 15 to 20 who attend regularly. And some of them have been coming since the group started in 2016. So this is a great resource to a lot of veterans who have connected with each other. Next slide, please. The next is GI Tunes, and this one is one that was very impactful for me. I found that in my recovery, there were days when I was so depressed that I couldn't get out of bed, and times when I was so anxious that I couldn't focus, and music was a great source of support for me. and I had created personalized playlist on my cell phone. So if I was in bed and depressed, I could turn on that playlist that would help get me motivated and out of bed. And if I was anxious, I had different playlists that I would use to help myself. So I had 2 occupational therapy students who came to me and said, we need to do a class project, and we would like to do something for veterans. What can we do? And I had no idea, but I told them about what I had been doing with music, and they took the idea and ran with it, very excited about working with a music therapist and creating a program. So we do have a program now that has been in place, I believe, since 2015, where we match veterans with music therapist who creates personalized playlists for them and then meets with them to ensure that they are finding relief with those playlists. Next slide, please. I'm going to go through these last few pretty quickly so that we do have a little bit of time for questions. This one is Battle Buddies, which is a peer support program. We have people who have received specialized training in helping people develop strong peer relationships with veterans, and this is going well. Next slide, please. Guitars for Vets is a national program, so wherever you are, you could have a program like this where veterans get 10 free guitar lessons, and once they have completed those lessons, they get a brand new Yamaha guitar. And in our community, we have found ways to connect those who have graduated to one another for increased relationship support in their life. And I know this slide says 98 veterans, but this week we graduated our 99. Next slide. We created a veterans response team. These are individuals who have been trained with law enforcement in helping de-escalate situations. So when there is a first responder going out to a situation that involves a veteran, they can activate the veterans response team and have a veteran who has been trained to respond with them. This program is fairly new. We launched it last year and have been able to help several veterans. Once we get them through this crisis, then we're usually able to get them connected with a battle buddy and other sources of support. Next slide, please. Hidden Heroes. This also is a national program that provides support for the caregivers of veterans. And this is just not caregivers of veterans who have physical disabilities, but also those with PTSD and other mental health conditions. Next slide. So how did I get the staff commitment and buy-in? I am a strong believer in what Brene Brown says about sharing vulnerably. And so I have been very open with my staff every step of the way. There, may be things that weren't appropriate for me to share with them, but anything that was appropriate for me to share with them, they knew because I told them when I recognized that I was drinking more than a safe amount of alcohol every night when I went home from work. And so I'm making some changes, and here's how you can support me with that. And what those conversations did is it opened it up so that my staff felt comfortable talking to me about their needs, and it made them committed to providing this type of care and compassion for all of our clients. Next slide. So you have my contact information, and you will have that in the slides. You can reach out to me if you have any questions. As I'm wrapping up, I think the things that I would like to share is, Dr. Flaherty mentioned you don't have to wait until you have a whole system buy-in to make changes. And the things that I would encourage you to think about that are things that you can do today. You don't need the buy-in of anyone at all. And that is, be like the people who are around the table when I asked questions and when I shared my experiences, who they didn't look at me as if I was less than. They did not think that I was now no longer a professional because I was able or willing to share this information at a professional table. They saw me in the community the same way they saw me in the community before. That is something that you can do today. And Zach talked about creating spaces of belonging. And I will tell you, with the three previous speakers that you heard today, these are three people who are very skilled at creating spaces of belonging. And when I watch them, I believe it is because in their heart, they genuinely care about creating a space of belonging, and that shows. So that is something that you can do within yourself, and make sure that you are allowing that to come through. And because I witnessed that from those three individuals plus the other people at the table, it increased my trust in the behavioral health care system, which made it feel safer for me to seek any additional help that I needed. So thank you very much for listening to my story. I hope it encourages you. And at this time, I will turn it back over to Alyssa and Jen for questions.
Yeah, if any of the attendees today have any questions for the panelists, please put them in the Q&A section. We have about 5 minutes left of today's webinar, so we'd love to get those questions that you have answered. While everyone is thinking of questions that they'd like to ask the panelists, I did put some reminders in the chat for you all, so I will go through those really quick. To please take 2 to 3 minutes to fill out that post-event survey. Certificates of attendance will be sent out via email to all who attended today's session in full, and the PowerPoint and recording will be posted on the Great Lakes ATTC website following 1 week from today. And lastly, if you haven't, please make sure you register for sessions 2 and 3. I did put that link in the chat, so we hope to see you on future sessions. And panelists, I'm not seeing any questions come through, so I will, if anyone has any questions, feel free to reach out to the Great Lakes production team, and we'd be more than happy to send that. Oh, we did get one question. Thank you so much. The focus seems to be on treatment and treatment and prevention. Will there be more focus on recovery?
Did you want to say something, Dr. Flaherty? Go ahead.
Just that I think that's a great comment. But all three are simultaneous. In other words, recovery measures that we introduced, and then the data that we have that Precia could talk to in terms of a number of people, finding recovery, defining recovery for them, measures of recovery, and the agencies themselves that measure, are they being successful changing their recovery management. But remember, this is an integration of recovery and the principles of recovery into the existing system of care. It's an integration of that. It's not a standalone recovery model separate of the system of care. That's the hard part, is to bridge those sciences with the spirit and principles of recovery. Go ahead, Precia.
I was just going to say that it's all recovery. So if you have a picture, picture the individual in the center, and everything we're building and everything that we're trying to do is so that individual can be successful in their recovery. And so it's about every part of the community embracing recovery, understanding it, and becoming engaged in how to help people sustain recovery, including individuals who are in recovery.
Mm-hmm. Yes. There are some unique studies now being done from this work that, at Brandeis and elsewhere, that are looking at pathways to recovery in individual populations. For example, African American defined pathways, and the unique pathways for women and unique pathways for different kinds of 12-step programs, AA or Smart Recovery. But it's all coming out of the Ross model now that we have a chance to stop and take a look at how people get well and how they can inform us by being well what we could have done better. And that's what is underlying all of this. Any other questions, Alyssa?
Does not look like we have any other questions that have come through, so I really
I could-
appreciate you all being here with us today.
Yeah, one last point to invite the attendees. The second webinar will focus on how this and how we addressed workforce and development of workforce, as well as some of the special populations. So I think that how we kept up with the challenges that many of you face day in and day out in terms of motivation, but also finding new workers and expanding outreach into new areas and populations.
And with that, I really hope that everyone can register for the next session. The next session will take place on July 11th, Thursday, July 11th, same time. So please make sure you register for that. So we hope to see you all next month. And thank you so much to our panelists. You guys were wonderful. As always, like another reminder, I will post the PowerPoint and recording to the Great Lakes ATTC website. So please share that out with everyone, and we hope to see you next month. Thank you all.
Thank you.
all.